NGH mission statement to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice.
Thank you. And our vision is to be the leader in exceptional community health care, one neighbor at a time. At this point, I would invite any of the members to declare if they have any conflicts that would keep them from giving an unbiased opinion or vote on any of the things that are being considered today. Is there any public comment?
No, sir, there are none.
None. Okay. Dr. Elders, I think you have some folks to recognize for us today.
Yes, good afternoon, board chair and fellow board members. I'd like to highlight two of our nurses here today. One is Christy Lamb. She was our February Daisy Award winner. The Daisy Award we honor quarterly, and for that quarter we had 12 nurses nominated from from 5th and 6th floor, ED, ICU, and labor and delivery, and she received 3 nominations and was the winner of that award, and so we just thank her for her dedicated work. I do want to say for that quarter, there were 5 nurses nominated from the emergency department. 6, oh, my apologies. 6, let me get that number right. Yes, let me get that number right. From the emergency department, I'm sorry about that. And our second nurse I'd like to highlight is Justin Scott. He received his RN level 4. So the RN Clinical Ladder, it's a structured career development program that recognizes and rewards nurses for their clinical expertise, professional growth, and leadership skills. And so thank you, Justin, for being here. We wanted to highlight those things. That's it. Thank you, sir.
Thank you guys for all the work you do and for being here today. And I like to repeat this, that the president of one of the large academic hospitals in this city, the largest one, told me one time that a hospital is a place where nurses make patients well. Doctors are helpful sometimes, but these are the guys that make it happen. Many of you know that yesterday the hospital celebrated its the 135th anniversary of its founding, and the celebration was well attended. Thank you for the board members that were there. The mayor made a proclamation, and I'm not going to read the whole thing, but basically says, now, therefore, I, Freddie O'Connell, 10th Mayor of Metropolitan Government of Nashville and Davidson County, do hereby proclaim April 23, 2025 as Nashville General Hospital Day. It's quite a great history. I mean, the first hospital was built in 1890 at a cost of $30,000. Wish we could do that today. Okay, we have lots of minutes to approve from 3 meetings. One was the regular authority board meeting of February 27, the call meeting of March 10, and the March meeting of 27. Our secretary, Dr. Nettles, I believe, has reviewed all of these. Do you or anybody have any correction or addition to those minutes? And if our legal representative will allow us, we can approve all of them at one time? Okay.
I'd like to say that the content is correct. There are some minor typos and errors that I would like to review and have those edited. Otherwise, the content is correct.
Okay.
And I would if it's appropriate to make a motion that these be accepted pending the edits, or is that appropriate? I just don't know. All right. So I'd like to make a motion that, that all minutes, be, accepted pending the minor edits.
Second, Mr. Lesser, any discussion? All in favor, say aye. All opposed? Motion passes. Thank you very much. Next on the agenda, under old business, is a status report from the PSA. We have several participants. Mr. Esco.
I will start because mine is an observer role on behalf of the board. To remind the board, I've been asked to attend meetings and report back because of the importance of entering into a professional services agreement with Meharry, which we have not had for a long time and poses risk to both the hospital and Meharry. I'm pleased to report that the meetings are very fruitful and they are occurring on an accelerated timeline. There are subcommittees that have been created, particularly a finance subcommittee to deal with financial issues and terms for this agreement between the hospital and Meharry, and also a joint hiring committee, which is an important component of the relationship between the hospital and Meharry. Those committees are active and are providing feedback to the larger group of Meharry and hospital folks who are participating in this. My understanding, based on our most recent meeting, or the meeting I attended most recently on April 9th, is that there is some optimism of completing negotiations on the PSA in the next couple of months. And so we may have an agreement for the board to consider and review. I think there's a lot of work that would need to be done in the interim, but the group seems very active, and overall, I'm pleased to report to the board that those negotiations are proceeding very well, and defer to Dr. Elders on any other additional information or more specifics that I've left out.
David, is there a goal that all providers will have an appointment with Meharry?
I will defer to Dr. Elders. I don't know.
I can answer that. That is our goal. And we're looking at pencils down probably in June, and a potential start date of July 1 is our hope. Now, I will say outside of the PSA, we have already agreed upon one joint hire. So even though we're unofficially in that relationship, we did send an OBGYN candidate to them. They did interview the dean as well as the chief of that service, or the interim chief of that service, and we are all in agreement of that hire. So it's a good start to that collaborative relationship. We have also added Dr. Inzare to the joint hire steering committee, so he will be participating with us on that. And I met with Dr. Hildreth on April the 21st and provided him a copy of our draft. That's all I have.
Any questions from the board? And we appreciate that progress and rapid progress. Thank you very much. Ms. Lewis, reporting on the nepotism policy.
How about now? Okay, thank you. Thank you. Here to discuss the new nepotism policy that we have. Nepotism, as our new policy defines, is favoritism in the workplace based on being a relative of an employee, and the relative is a defined term. This new policy has been effective in March of 2025. I'll be happy to give you the timeline of the events since we have had implementation. On March 14th, the policy was sent to all ELT members for input and for approval. The nepotism policy was then uploaded on March 17th into PolicyStat. On 3/18, the ELT was notified of the policy, that it was uploaded to that. At 3/26, there were town halls held in both the morning and the evening, informing them of the nepotism policy. On April 14th, all future staff are required to sign off and disclose on the policy. And on April 14th, the new policy was discussed at the directors' meeting. On April 17th, also, there was a deployment of the policy to all current employees to acknowledge as part of their employee learning system through Halogen. And on April 30th, the nepotism policy will be highlighted in the monthly newsletter that goes to all staff. So it has been vigorously incorporated into our current culture that we have. The former policy was based on the 2019 language from the Hospital Authority Civil Service Rules and Regulations. Now,
Any questions?
Just a brief question. Under item 2B, the relationship may not create an actual or perceived conflict of interest. How is perceived defined, and who defines it at the time?
That is a very good question. This was supposed to have been introduced in tandem with our conflict of interest policy. And so that is where the reference to the conflict of interest would occur. And so in our conflict of interest policy, there would be a definition of talking about actual or perceived conflict of interest, and that would be a cross-reference that would have a reference to that. That is where that is. To answer your question more directly to what would be actual or perceived, if there is an actual, meaning if there's an actual violation of that, I think that would be self-evident. If there is a perception, I think that would come with a different type of relationship. There is an expansion of the definition of relative in the new policy that extends to domestic partners. And so if there is, and the domestic partner is someone with whom you have an interpersonal relationship, that you live in the same residence with that person. So I think there may be, whether there is a perception of a conflict of interest, a potential might be the better word instead of perception. We can make that amendment if we need to for clarification. But that is where I would anticipate that the perception of it would come into play. Okay. Do we need to go over any distinctions in the policy, in the new policy? I can do that if requested.
Well, I just have a question for legal department. Should this policy be approved by the board? A, and B, what the status of the conflict of interest policy, which last month was still being reviewed, I think.
Okay, on the first question, these are internal policies, primarily HR functions and so forth. I believe you've delegated authority, and the hospital itself is able to adopt these policies. So I don't think it's essential for the board to adopt or approve it. On the conflict of interest, though, that is going to be applicable to both board members and hospital employees, and therefore my recommendation when it's finalized is it will come before you. This information will in some respects be incorporated into, and as she alluded to, as part of the conflict of interest. Not the disclosure on your parts, but on the conflict of interest. As an update on the review, Metro Legal has retained an attorney to provide 10 hours of work per week for my team. And his assignment, number one, has been to work with Christy. He'll begin next week reviewing the conflict of interest policy, and so it will be available. I've already provided the deadline in advance so that it can make your agenda posting the week before your next meeting, your next regular meeting, just in case you had a special meeting in the interim. All right?
Thank you very much.
You're welcome.
For clarifying. Any other questions for Ms. Lewis? Great. Thank you for bringing that to us.
Thank you.
And getting it implemented so quickly.
Thank you.
Dr. Elders, update us on the internal audit
Yes, sir.
response.
Thank you, sir. Dr. Martin and I met with one of the investigators on April 11th. Prior to that, I watched the Metro internal audit meeting, and then prepared this statement for the Hospital Authority Board, which is in your packet. For allegation B, that action plan remains in progress. It's in regards to city valet. We have on April 9th issued a formal notice regarding the termination of the actual valet parking services agreement, and we no longer have the service. We did the 90-day notice to adhere to contractual terms, even though the vendor was in breach, and we no longer have the service. Once that's completed, we'll bring that back as well. If you look in blue, those were the concerns that were elevated from the Metro Audit Committee. I won't read them all to you, but we did want to address them, and I have discussed them with Dr. Martin. For allegation C, which was the specific clinical and non-clinical contracts from the Hospital Authority Board process, that action plan remains in progress. Now, we have completed the education development for that, for this allegation, as well as the intelligent contract software, but we're still needing to roll that education out to our leaders, in which they will have 30 days to complete that education once it is assigned. The concerns from the Metro audit is listed in blue there. If you look in that box, if you turn to that page, they were asking about what the company was and the service and the term date or end date, and I've listed those out for you. Just for full transparency, we will be bringing the KJ Trauma Consulting contract back to the board for approval, and the Curay Group, which is GI equipment, which is the contingency firm, and then the Sonosite, which is gastroenterology service line equipment. Those three will need to come back to the board. We're looking at keeping those services, so I do want to bring those back to the board for approval, but it will be in May. I couldn't meet this deadline. For allegation D, which is in regards to Dr. Billups, that action plan is complete. And then allegation E, we are looking at DocuSign and Adobe. We've got both quotes. I think our CIO has looked at both of those, and we are going to go with the DocuSign. So once that's implemented, we will bring that back to the board as well. During that meeting, we were asked to provide our education to Metro Internal Audit, which I did, as well as all termination letters and ends of agreements. And we plan to meet with them within the next couple of weeks to finish out this piece of internal audit. I do want to give an update on a human resource audit that was conducted in October of 2022. Those recommendations were satisfied in 2023, but they did come and perform a re-audit in March. And we've received a letter saying all of our recommendations on training, interview notes, and hiring practices without deficiency are complete at this time. Any questions?
May I ask a question about allegation B for the valet?
Yes, sir.
One note on page 2, subsection F, says there's a conflict of interest that will be addressed with the board. Can you talk about what the conflict of interest is or may be with the valet contract?
Well, it was more so, I'll say, in regards to the executive secretary's role in ensuring contracts come to the board. And so we did discuss that. Janet is, she just provides what the executive leader provides from the contracting approval form and things of that nature. So Dr. Martin and I did discuss that. It was elevated in that committee, which is why that note is there.
Okay. So if I understand correctly, there's not an ongoing conflict of interest?
There may be. There was an email that was relayed to us in regards to the vendor and an association with a Metro executive director, which we're still looking at. Not ready to disclose.
All right. If
those
it's premature,
details yet.
it piqued my interest, of course, because
I understand.
when a contract doesn't come before the board, or a number of contracts, as the audit found, then I think the board is justifiably
Absolutely.
interested as to why it is that was done. So conflict of interest might be.
Well, one of the things, just in full transparency, the city ballet contract actually started in 2015, and it started as a proposal. The contract that the Metro Internal Audit looked at was the 2023 contract, which is the questions that I answered. We are looking at getting them a timeline of the city valet, Paul, the investigator, and so we're still working on that. So we will meet again about that.
And I appreciate your efforts on this. One other follow-up question on that is I noticed the audit findings were that there's a big discrepancy between the amount that the hospital paid and the pay records, the time cards for the employees who were supposed to be providing the service, and at the very least, there was not proper documentation. Perhaps they weren't there at all. I guess we don't know. But my question is, we believe that we're owed money. I noticed that it says legal action may be required against City Valet if we believe that we're owed money. Maybe it's a question for Metro Legal or somebody who's familiar with that 2023 written agreement, whether there's a provision that states who pays for legal fees if there is a legal action related to breach and someone is found to be in breach. Can we recover the costs of our attorney's fees if we can prove a breach and get damages in a lawsuit?
Yeah,
Do we know the answer to that?
I would need legal help for that.
Metro Legal hasn't been presented with a request to review that contract or render opinions.
Okay.
I mean, it could be coming, but we don't presently have it. So
It will be coming. If you look, the letter that we sent out requested a response by April the 21st, and we have not received a response.
Okay.
And so it would be upon us to initiate that action, and I'll work with Dr. Blackledge to do so.
Great. Thank you.
Other audit response. Okay, thank you very much. Yes, Dr.
I will say one more thing, as it was alluded in the Finance Committee. I have, and this team has committed to a strict contract signature process, as you see from the contract submittal form that has been submitted in the finance packet. And I've refused a couple of signatures and sent them back. And so just know that we have our safeguards on. And Christy knows I won't sign anything unless she's signed off, as well as Dr. Blackledge. Thank you.
Thank you. Medical staff bylaws status, Dr. Bullock.
Is it on? Okay, good. Good afternoon. I am Deanne Bullock. I'm the Chief Medical Officer. I'm here to give two updates on the medical staff. The first one is the bylaws update that has been transitioned over to me as of last week. We are working with the bylaws committee. There were some delays in some prior meetings due to spring breaks and all kinds of other vacations. We did have a very extensive meeting the other night for about three and a half hours. So we are continuing to move through that document at a good pace. We are still using the document that has current Joint Commission requirements and legal requirements in it. So we're kind of doing a side-by-side comparison and doing modifications as needed. We are going to do some speed up meetings over the next 3 to 4 weeks for the ones that were missed and still are hopefully on timeline to hopefully get these done by the annual staff meeting in June. Does anybody have any questions on the bylaws update before I move on? Okay. The next agenda item is the medical staff engagement survey that we do have a date for. That will be it'll kick off in May. The official date is May 12th. That will be 3 weeks, and that will also lead into the employee engagement survey. I am working with marketing so that we can work together to really make sure everybody is aware of this, hopefully providing some of the questions so they can review those prior to. As part of that as well, we will be relaunching the medical staff newsletter. We'll do a brief edition probably in the next week or so, definitely before the engagement survey goes out, and then ultimately go back to a monthly or bi-monthly cadence on that, really just to speed up communication and provide communication to our entire medical staff, as not everybody is an NGH employee. Does anybody have any questions on the medical staff engagement survey? All right, those conclude my 2 reports, and thank you.
Thank you, Dr. Bullock. Dr. Miller, the credentials report.
I would just like to make a comment.
Yes,
that
please.
I appreciate how quickly the transition is being made in this new position, and thank you very much.
If I can go ahead and just add here, as you guys know, I have privileges here, and it's been difficult getting things started. And Dr. Bullock, we've had a relationship now professionally for 4 years now, and I agree. I just wanted to chime in and say it's just been seamless, and I know how hard you're working to get this process going. I'm really confident that we're moving in the right direction. So thank you.
Thank you for your
And
comments.
we want to thank you for kicking in and doing some vascular surgery here at the hospital. That's been a very valuable contribution on your part. So the Medical Executive Committee met last week. It was a brief meeting. We did not have a quorum at the time, but I think that the things that we needed to vote on have been approved by email. We did have a quorum in that way. We only had really one medical staff change, which is Dr. Faulkner, who went from active medical staff to emeritus status, and that was really the only medical staff change.
I believe the credential report requires approval. And the report, Dr. Miller's report, constitutes a motion. Do I have a second? Any discussion? All in favor? Aye, please. Aye. All opposed? And motion carries. Thank you. Quality report, Ms. Rogers.
Is it on? Okay, thank you. Okay, I'd like to start off with welcoming Dr. Tamika Hudson to the Quality Management Committee. Dr. Hudson, thank you for serving on this committee. We look forward to you being on the committee and providing your information. I'd also like to thank Mr. Lester for spending some time meeting with the quality and the patient satisfaction survey team this earlier in the month. We had great conversation, and he gave some good suggestions that we plan on implementing in the future. And I would also like to thank you for offering to be on the patient advisory committee as well. So thank you for being on that committee. If you do look at your dashboard, there are changes that have been made based upon the feedback from our last meeting. First of all, we've added a column on the dashboard that shows an annual trend line. It'll be at the end of the report, at the end of the dashboard. We've also gone back to monthly reporting rather than quarterly reporting for patient satisfaction survey responses. In addition, we've added hand hygiene total observations row. This row represents the goal that is actually measured by Leapfrog. We have continued to have the hand hygiene compliance rate. That's internally so that we know if we're showing improvements internally. And finally, I do want to let you know that at the end of this report, I'm going to ask Sherry Oliveras to come up and speak to the patient satisfaction survey and give us some information on addressing the plan to increase the number of responses and to provide information about what other hospitals do to increase the number of responses. So moving on to the dashboard, the first goal that we have is the safety of care. Our goal for falls within injury, we do have opportunity there. We did have our goal was not met. We did have a fall this month. We have initiated a rapid cycle improvement process to identify any opportunities to reduce the risk of similar events and to implement action items. The Falls Committee will continue to monitor feedback from these processes. For hand hygiene, our compliance goal of 95% was not met, but increased from 90 to 93%. Our target for hand hygiene compliance is 100%. And we continue to try to reach that even though our goal is 95. We continue to routinely communicate with leadership about compliance observation counts and encourage all to coach in the moment when adherence is not observed. Our observations performed goal, the new column, or excuse me, the new row, our goal in all departments was met. And this is the goal, like I said, that is measured by Leapfrog. For barcode medication administration, our goal of 95% was not met, but we increased for the second consecutive month to 94%. And our target is for all medications to be scanned and to positively identify each patient 100% of the time. We continue to work with nursing education to ensure the patient location is updated when patients go to ancillary departments for care. For our quality of care goal, healthcare acquired infections goals were met for 7 out of 7 of the metrics that are measured, and we remained at 0 events for greater than 260 days. The data for timely and effective care goal is still pending due to Cerner quality reports being validated. We have a target implementation date for this validation to occur in June of 2025. For our patient-centered goals, which Sherry will talk about later on in a few minutes, our cleanliness and quietness goal of 72% was met and increased to 85.7%. Our responsiveness of staff and willingness to recommend goals were not met, but scores did increase to within 1.3 and 2.6% respectively. We have, along with this goal, we have re-implemented monthly reporting with a goal of receiving 30 surveys each month, and that is reflected on the dashboard as well. Our staff engagement goal has been deferred until the 2025 survey is completed, which will be completed the survey will take place in June. And finally, our regulatory, we've had no complaint surveys for the month of March. That is my report. Are there any questions? Okay, Sherry, would you like to come up and discuss patient satisfaction survey? I know we had some lively conversation about this at the last board meeting, so we thought we'd.
Hello, my name is Sherry Oliveras. I am the Administrative Director of Performance and Operations. I know you had some questions last month about best practices and how we're going to get our survey number increased. So what we've done is we go around to every department. We're teaching our employees first what is press gaining and how important it is to them and know their role with the press gaining. Then we teach our patients as well. We let them know you may receive a survey and how important it is for you to fill it out and send it back in so we can improve our services. So we kind of get the patients involved. We have a ambassador that speaks with all the patients, new admit, every single day, so that she's constantly reminding them, is everything okay? How's your service? Reminder, you might get this survey. We have not had an electronic survey offered for the inpatient, and they are offering that now, so we're getting that into the contract, so it'll go a lot quicker than mail. So we're hoping that would help get those up too. For April, though, we do already have 13 surveys in, so we have increased our number for inpatient. What were some of your other questions? There are some changes in the cleanliness of the environment. That used to include quietness. That is now changed, so it's just by itself. So the environment question is just going to be how clean the facility is. Responsiveness of staff, it has also changed too. It is helping to the toilet as soon as you need it and receiving help as soon as you need it. So we can target those two questions with the inpatient to help those scores increase. We are also sharing the undeliverable rates. If a survey couldn't go out because of the wrong email, a wrong address, a wrong phone number, we can share those with the frontline staff and say the importance of getting the right information on the front end. Any other questions that y'all may have? We have a lot going on in patient experience.
Question?
Yes. Thank you for coming and providing that additional clarity. I do remember there being a robust discussion on last month. So this is really helpful, and I think too, tweaking the survey to be more reflective of some of those concerns. Your dashboard serves as an action plan and a display of data, somewhat action plan in regards to goals, but is there like a formal action plan that's timely and measurable? And I'm sure there is, but I think it would be helpful for us to get a better understanding of how you plan to increase these numbers.
We can compare ourselves to our region and also safety net. I heard that before, though. I got our safety net hospital, and we compare our numbers and we set our goals accordingly. And when they reach the goals, we can raise those goals. And like right now, recommend the hospital, we are the same as our national average. Though 70% is not great, we want to say what a great job y'all have done. Look where we are compared to everyone else, but we can do even better. So that's, Mr. Lesser sat in with some of our training on that, and we do want to reach 100, but we set small goals so they can reach it.
But is this a strategic goal that has clear individuals assigned to these tasks that you're monitoring? Is it possible? Well, I guess as I join the subcommittee, I will have access to that. Yes. But I think that the board will enjoy having that information. So maybe more to come, board. Okay, thank you. That was helpful.
Any other questions?
Just a side comment, if I might. I watched the first episode of a program called The Pit. And it's very fast moving. I didn't understand much of what was going on. But when they referenced Prescaney, I knew what was happening. So thank you.
My job is done. Thank you.
Prescaney is ubiquitous.
And I will say, if you've only watched the first episode of The Pit and it was fast moving, when you get to the later episodes, it becomes difficult to watch. As a non-medical person.
Let me say, I don't believe we see Dr. Elders coming down to the emergency room.
Order. Thank you for the improvements that we're seeing already, and also for adding the elements to the quality report that we asked for. Move on to our committee reports and call on Mr. Esquivel for the CEO Search Committee.
Thank you, Mr. Chair.
We should have approval. Do I have a motion for approval of the quality report?
So moved.
All right, second. Thank you. Any discussion? All in favor, aye, please. Aye. All opposed? Motion passes. Thank you.
Thank you, Mr. Chair. The CEO Search Committee met for the first time on April 11th. Our next meeting is April the 30th, so that the board is aware we're going to have a general cadence of meetings scheduled every 2 weeks. We think we need that type of cadence in order to move this process expeditiously, which is in everybody's interest. We want to find, of course, the right fit, the right candidate. We're going to do the substantial groundwork that will be necessary for finding the right person for this position. But so that's to say, on scheduling, the committee is going to be meeting regularly and frequently. At our first meeting, we let me start in the order that's on the agenda. The discussion and funding for a third-party consultant. We think it is absolutely imperative that we have a third-party search firm to engage to assist the committee in its work. This is likely to be a nationwide search. That's not to say that there's not a local candidate or an in-house candidate that will emerge or that will ultimately get the position, but in order to cast the widest net, we think that that is appropriate. And because of the work that's required, not just to go through the process of collecting interest and collecting resumes and doing that work, the committee believes that it's really important that we talk to all of the stakeholders and constituencies that are important for the success of the person who's going to have this role. So that will obviously include board members. It will include hospital medical staff. It will include all hospital employees to some extent through surveys or meetings or otherwise. It will certainly include our partners at Meharry Medical College. It will include people in local government, community leaders, other healthcare providers and institutions in our communities. The committee believes that it's important to survey and involve, to a certain extent, a broad cross-section of our board employees and the community in order to really understand what we and the community think are the qualities and skills that we are looking for in our next CEO. So all of that is to say that that's a lot of work to do, and it's not work that the individual committee members volunteering their time and the existing hospital staff who already have 120% of their time allocated to the work they already do to be able to do that kind of work. So we began on our first meeting having a presentation and discussion with a firm called AMN, which we also sometimes, or we may hear referred to as B.E. Smith. This is a search firm that the hospital has engaged for the last 10 years. 10 years ago, the hospital went through an RFP process, did a public procurement, selected B.E. Smith, which was later acquired by AMN, to serve as the hospital's provider for this function. And B.E. Smith, over the last 10 years, has helped the hospital with interim executive level placements, other placements. And so we met with them because it makes the process smoother if we use an existing vendor. We have the option to engage them because they are already selected through a procurement process. If we want to find that we want to consider other options, and there are certainly other CEO search firms, executive search firms that do this, we would need to open it up into a public process, and that will take some time. A ballpark estimate is, I don't think that process could be done in any sooner than 4 months. In terms of creating a request for proposal, putting it out for bid, and, inviting search firms to submit proposals, do interviews, conduct scoring, and then eventually reach a decision. So that's the immediate decision that the search committee has before it, which is, do we go with our existing vendor, or do we go out into the market and once again see what options we have for search firms. I invite any of the members of the committee to weigh in on their thoughts of AMN, their presentation. I was generally impressed and pleased and thought that they demonstrated credentials and had the right idea of who we are as an institution. They know who we are because they have worked with us for a long time and understand our values and the kinds of leader that we'd be looking for, the kind of process we want to pursue. But I think the agenda item for our next meeting on April 30th will be to make that decision as to whether we want to engage with them or do we want to see what other options there are. We have to pay for this, and so we've been talking about where the money will come from to do this. We have yet to negotiate with AMN if we do enter into a contract with them and they serve as our search firm, but I want the board to know that we will negotiate strenuously with them given our financial condition and given wanting to be good stewards of our resources. But just so that the board is aware that, there is a cost associated with employing a firm like this. I think it is well worth the investment for the future of the hospital and the institution, but there's going to be a cost associated with it.
David, have you talked to them about payment models other than the one that they gave us?
I have not yet, though I plan to. I first wanted to gather some information. So the accounting group has provided me with history of our engagements with them and the amount of business we've given them over the last 10 years, for lack of a better word, which, as I understand it, is about $1 million worth of engagements over 10 years. And so I wanted that information so that when we go to them, one thing would be to sort of negotiate along the model that they've proposed. They have sent us a cost proposal that is structured as a percentage of the compensation that will be paid to the person that we offer the job to. So we don't know what that cost will be. It will be depend on what the pay package that we offer the person that we offer this position to. I think, Dr. Miller, in line with what you've asked, I will intend to ask them for a different model, which is if they were to estimate this as a fixed fee proposal, because I think there's some advantage to us to have a certainty of cost rather than uncertainty of cost, whether they would do that. My understanding is that in this industry, a percentage of compensation is a very common way to do it. So it may be that they will say that's not how we do it in our business, and then we can determine whether that's good enough for us or we want to go out into the market and test that. But I absolutely will ask them to consider other methodologies, because I think it's important, particularly with our finances right now, to have some certainty as to what this is going to cost, as opposed to being depending on what we eventually offer as a pay package.
I'd just like to add that that particular meeting was, I thought, quite productive. And there were at least 10 questions that we had generated just on the spur of the moment, and they were very well prepared in answering those questions, and I think quite candid, and I think that we were fairly candid with them as well, given the history that we have. And so in terms of looking at, 20th century versus 21st century and what the vision for the hospital is about, it seems as if that they were quite astute, had done their homework, but also are listening to what the needs of that we need, that are before us. So it was very impressive, and every minute was very well taken.
Yeah, David. First of all, congratulations to you and the committee for what seems to be, thus far, in such a short time, a very productive meeting and the thought that you all are given into this. And I'm just curious, sounds like that was a very impressive meeting with the current provider. Short of going through what you said was a 4-month process with engaging others potentially to pursue the result we need, is there a way of at least having an informal session with an alternative, just to get an idea what somebody else might put on the table?
I will defer. I don't know if Diana Wolfhart is here or, yes, she is. She could speak to this. My understanding, and correct me, Diana, if I'm wrong, that as a public body or a quasi-public body, we cannot simply call people up and say, hey, can we talk to you about engaging you? Public contracts have to be put out for bid. You have to have an open competition. So it's much more strictly regulated than if we were a private entity. We could have exactly those meetings. As a public entity, we are required by law to conduct a formal competition to engage something like this. But Diana, let me know if that's...
No, that is correct. We follow the RP process that Metro has in place. Also, I believe that you did speak to someone at Metro, another vendor that is also in the system already with Metro, a qualified executive search firm. Is that correct?
I can report on that. I had a conversation. Our second option would be that because of our relationship to Metro government, Metro also has a contract with an executive search firm. It's a firm called Insight Global. I had about a 1-hour preliminary meeting with representatives from them. My strong belief is that they candidly said they don't have particular healthcare expertise, and they kudos to them for pitching it with the best light possible, which is to say they thought a well-rounded experience would be good for this type of search. And so even though they don't really specialize in these types of at all in these kinds of healthcare placements, I think the consensus in talking with Diana and others in the organization is that this is the type of role and job that really benefits from a firm that specializes in healthcare. And it's such a unique industry. The skill set, the relationships with people are such that you can't really just be a generalist search firm and provide the kind of advice and skills and expertise and knowledge that is needed, particularly for, searching for the CEO of a major city public safety net hospital. It just requires it. That's my view. I think, others share that view. So just in the full disclosure, there is another option. I don't think that they really have the qualifications to do this.
Mm-hmm. And there is an RFP that has been proposed. Mr. Escobar has it. But the timeline is, as he stated, because of the gathering of the data, having people apply, and then excluding, kind of like it was done with the marketing RFP. So if you remember that process, when you're on the board, so that's the same type of process that we would go through. And that's why the timeline is so long, because you have to gather, give an opportunity for people to apply, and then go through the process and rate, and then allow each to present, and then choose based on who you think is the best based on what they provide and the cost.
Okay. I'd like to point out that the AMN group, when asked how long from today we have a new CEO in the office, they can't say, but roughly 6 months. So if you add an additional 4 months to look for another search firm, then we're almost into a year. Thank you, Diana.
Yes.
I have a quick question. You mentioned including community members and individuals from Meharry. Have you already identified those individuals? If not, when will that take place?
I am not, and I would look to the search firm to help us do that work because they have done this other places, so I think they can talk to us about the type, and I think that is absolutely, we would have that discussion at the board level within the hospital with our partners, like who is it that we need to reach out to and say, and candidly, that is, to me, there are two important parts of that. One is we need the buy-in of the larger community in a decision like this. And we will benefit from involving people in this decision and providing us, ultimately it's the board's decision, but I think it will be helpful. I think after we make our selection, it is also helpful to have had a broader cross-section of the community have a stake in who this person is, because it will have a broader cross-section of the community have a stake in the success of that person. And we all want that person to be successful because we want the hospital to be successful. So I have said, and I would intend for the search firm to help us figure that out. I mean, they can't tell us exactly the people, but they can tell us who are the institutions in other places, and we will have our own thoughts as to who those people are.
I couldn't agree more. Thank you.
And I would encourage you, Dr. Hudson, and any board member who have suggestions that they think are important to send them through Janet to the committee. I know I've got a list already. Okay, yes, Mr. Leslie.
Yeah, if I heard you correctly, and I understand the process by engaging members of the community at some point in the process, which I think is a superb idea and necessary for our hospital. But did they suggested that it would be a 6-month period to once the process began before we would have a CEO on the job?
Correct.
That's quite unusual in the business world. And I know this is a little bit different, but 6 months is extraordinary amount of time from start. It's way too long. It's way too long. I've never, in my experience, seen a process take that long.
I mean, I think that they outlined a lot of different things. You know, one is, you know, they need to put out an announcement that we're looking for a CEO. They have to screen resumes. Then they interview those people that they're interested in. You know, and then there's also a little bit of a timeline. And if you identify somebody, then you negotiate what the contract looks like, and then there's a little bit of a delay of when they actually show up to work. So if they have to move from another city, so it seemed like it was a pretty well-paced process. They laid it out pretty clearly.
And we, you know, this was asked a week ago as we were just starting. We presumably will make a decision next week. So each little step takes time, and I think what may be different from some business situations is the importance of community and partnership engagement.
Totally agree and understand that. I just think it might be helpful if, in fact, we decide to go with this particular organization, to see if that time frame can be collapsed a bit. 6 months is an extraordinarily long period for replacing a CEO, and I just think that's absurd.
Okay. Thank you, Mr. Esquivel. Does the committee have any recommendations at this point?
I do. I want to make sure Dr. Fisher has an opportunity, because this input is helpful. If the board, I mean, the committee serves at the pleasure of the board. And so if the board's view is that this needs to move much faster, then that's very good input for us and whomever we select.
I do agree. I think a 6-month time frame seems like, while it's going to take, it's a process. I think we need to be mindful. I think if we put our minds to it, that we can do that in a shorter time frame.
And some of that will be collapsed depending on who we choose. I mean, we know that some people can stretch out a negotiation process, and then if they do have to move, there are some personal things that sometimes you can't start 2 weeks later. So I think that their process was pretty quick. I guess we ought to bring that to you all.
Yeah.
Just one other thing, and I think you might have mentioned this, but, you know, being a safety net hospital, obviously they've looked for the right individuals and the right people in those particular hospitals, and hopefully we can query those organizations, or I don't know if there is an organization that of leaders in the safety net hospital kind of network, if you will, and if we can get some maybe some input from them. I don't know if that would be valuable or not.
I actually, one of the things that reassured me about them is I'd had a conversation with the CEO of Parkland Hospital in Dallas to specifically get general advice about conducting a search like this, but also in particular. And he mentioned 2 search firms that he said were regarded as the people you would want to hire for exactly this type of search, and AMN was one of them. So it was very reassuring to me that at least, and I think I would hope that AMN would bring those kinds of relationships to us and say, when we did this search in Dallas and Charlotte and Atlanta or whatever the thing is, I think that we could benefit from that.
And there's, I mean, the word is out. I mean, it's known nationally, you know, that we are looking for new leadership, and we already have names that are asking to be considered. So this is not just local.
Yeah, and that's a good point that you raised, that there are people that are already interested because the news is out. And search firms that have a particular area of expertise already have in their minds people throughout the country that are on their list. And they may not be looking for a job, but they're the kinds of folks that they will go after. An executive search firm, a good one, will not go after unhappy people. They will go after people who are really good at what they do and are happy where they are. That's kind of a basic tenet of an executive search firm. You don't want somebody unhappy coming here. You want somebody who's good, who's been doing a great job, has a great reputation, and doesn't know that they're on that list.
Does our committee have the ability to hire this firm, or do we need to wait and bring it back to the board?
I think because it's a contract, we would have to make a recommendation and negotiate with them, and then I would think that we would need to bring a contract to the board for approval, and that would, we can't finalize an agreement until the board votes to approve that contract.
We won't have an agreement for a month.
Not unless we convene a special meeting, but yes, that's right. But I think a month, a lot can be done. I mean, I will assume that we can negotiate a contract, bring it to the board at our next regular meeting, and in the interim, the search firm, on the assurance that the board, with no guarantee that the board will approve the contract, may be able to start doing some work before the board approves it. I mean, that's on if they are willing to take that risk, then they can start doing work, not knowing that the contract is yet pending formal approval by the board. I shouldn't say formal. The board can reject it if it wants to reject it.
Well, it's worth considering whether, we could probably shave 2 weeks off of it by having a call meeting.
I'd just like to provide another set of lenses in terms of the time factor. This is a patient-facing institution that we are making a major decision about. And so a lot of times, if, for example, that individual is providing direct service, you just can't say, well, I'm ready to start next week. I mean, that you have to do clinical patient work. You have to do the right amount of termination in this type of world. And so it may not go as smooth. So that's just a different set of lenses. And I understand the expediency, but at the same time, I think that we're in a position that, we can really enjoy the resources in the search and things will be done very well. So, I mean, I just think we're in a great place. But I just want to say that it may be a little bit different when it comes to healthcare.
We appreciate all the comments. Can you proceed with your report?
I'm sorry. I know you want to move along in the agenda.
Yeah, but
I cannot. But I'm sorry. I mean, one more, because something Dr. Nettle said was just resonated with me. Having done a search for a local philanthropy to replace the CEO, going through an extended process, we learned in that organization a lot about the organization itself by conducting this search. Like, we really honed our values when we were forced to say, here's what the qualities of the leader that we need for this organization. So I think there is a lot of value, and it's we need to do it expeditiously, but also we're going to learn a lot about who we are as part of this process. Okay, I will go to the action item. I'm very pleased to report that the other item on our agenda at our first meeting was to discuss the interim CEO role. Our initial charge as a committee was to determine whether we needed to conduct an independent mini search for an interim CEO while we conduct this full CEO search. The unanimous view of the committee, and strongly unanimous view, was that Dr. Elders has been doing an excellent job as an interim manager. And we believe that in the committee that there's no reason to conduct an interim CEO search, that Dr. Elders ought to continue leading the hospital in the CEO function and be appointed the interim CEO. And that comes as a unanimous recommendation from our committee.
Thank you. And that's one reason we can spend the time is that we're in a good place as far as leadership right now. So
Also have to make sure that she has an appropriate financial package.
Well,
Absolutely.
in that vein, I would refer you to a resolution that is at your place, if you hadn't had a chance to look at it, that is prepared by Metro Legal with my input. But first of all, this is the recommendation of the committee is a motion. Do I hear a second to a motion that?
I second.
Okay. Well, as for discussion, let me refer you to this resolution. I'll read a little of it, but let you read most of it. It says, whereas the Hospitals Authority Board of Trustees with a quorum of its membership met on April 24, and whereas Dr. Veronica Elders has served admirably in the role of managing agent since her appointment on March 17, and whereas the board has determined it to be in the best interest of the organization to appoint Dr. Veronica Elders to the role of interim Chief Executive Officer of the Hospital Authority. And it goes on to give some of the terms. You'll see a augmentation of her salary in there that is based on information actually from AMN and is based on a 50 percentile for an interim CEO in a safety net hospital. And it goes on to say that this will be retroactive to March 17 when Dr. Elders took over, and then it does include her services as CNO and interim CEO, and that when the CEO is in place, if Dr. Elders desires to continue her work as a CNO, then she will revert to her current salary. We will vote on the recommendation and the resolution together, and we will work on a contract, assuming that Dr. Elders agrees to this and it passes the board. But this resolution will allow us to go ahead and start paying her for what she's doing, retroactive to April 17th.
Move
Mr.
to
Smith.
approve.
I think you have a motion and a second to adopt the recommendation from the committee. So you've given a prelude to the other agenda item, but I think that matter should be voted first. And then when you get to the resolution, perhaps there won't be as much discussion necessary.
I make a motion to,
Wait a minute, there's already.
We have a motion and a second on the table to name Dr. Elders as the acting CEO. Is there any discussion of that, further discussion of that motion? All in favor? Aye, please. All opposed? That motion passes. And Dr. Miller?
I'd like to make a motion that we adopt the terms of this resolution for, I guess it's basically for her to become interim CEO and the compensation package.
Okay. Second. Any discussion about the resolution? If not, all in favor? All opposed? Motion passes, and we're very fortunate. All right. Dr. Nettles, before you leave, we'll need your signature on this. In fact, I'll pass it to you right now. Do pass that down to Dr. Nettles. Okay, thank you. And this is, really the most important thing that's going to happen in this organization in the near future, and I really appreciate Mr. Esquivel's taking this on in addition to the other things that we've asked him to do, and I feel confident in the way we're moving forward on this. Finance report, Dr. Hudson.
Good evening. So I had the privilege of chairing the Finance Committee meeting prior to this meeting in Christy Smith's absence, and we heard reports on March financial statements and revenue cycle, and so I will invite Dr. Blackledge to present. Thank you.
Thank you, Chair. Keith will share the financials. I'll be present to answer any questions along with Keith if needed.
If you notice, we are doing March financials. Second month in a row or previous month, so fantastic. So All right, so.
And Keith, I'll just make a quick statement as well.
Yes.
This is for information purposes. We did not need to approve it as they continue to kind of fine tune the finances. Thank you.
All right. All right, we're going to go over the patient volumes for the month of March. So the inpatient admits decreased from 296 to February to 232 for the month of March. It was above the budget of 220 admits. Inpatient admissions decreased from 10.6 per day to 7.5 per day, which was 5.5% above budget and 6.5% above year to date for the same period last year. Inpatient average length of stay is 4 compared to the budget of 3.9. Our case mix index was 1.16, and it increased to 1.28, which was lower than the budget of 1.31. The ER visits was 2,252, which was an increase compared to 2,103 for last month, but we were under budget by 83 visits. Our surgery cases were 27. Our budgeted was 27, but the previous month surgery cases were 43. This is for inpatient. For outpatient, our surgery cases increased from 93 last month to 100 this month. The cath lab volume, we had no volume in the cath lab, but we did have volume in the interventional radiology. It dropped from 31 to 28. That's a new statistic that we're reporting on our financials. Our deliveries dropped by 20% from 40 down to 32 from the prior month. It was one delivery above budget. Our clinic volume was 4,645, which was an increase compared to 4,325 last month. Year to date, we're 26% above budget. So we're 39,971 compared to 31,713. So down to the income statement. The total revenues for the month was $22.5 million, which was 20.2% below budget. Our inpatient revenue for year to date is 5.6% or $3.9 million below budget mainly due to the cath lab. And that's both inpatient, outpatient is due to no volume in the cath lab. So the outpatient for year to date March was 13.4% or $24.2 million below budget. But our net patient revenue for the month was $4.45 million, which was $924,000 below the budget. This was due to lower contractual write-offs and bad debt write-offs. Our net patient revenue percentage of revenue is 19.8, which is above the budget of 19.1, which is good. Going down to staffing and expenses, our salary expenses of $5.56 million were $473,000, or 9.3% above budget of $5.1 million. Our pharmacy supply costs increased, almost doubled, but that's because of how we buy pharmacy supplies, so it's up and down, so you'll see a variance there. Our supply expenses were pretty much on the previous month, $956,000 compared to $938,000. Our contract services, physician services, and repair and maintenance were below budget, and that was mainly to some cost savings, and also due to we're very aggressive in doing our accruals, and we made a few over accruals, and we reversed them, so that caught us up to date for the year. So our overall results was $12.2 million in expenses, 4.9% favorable to the budget. So we were below budget in expenses for the month. We had a net loss of $1.4 million for the month compared to a year-to-date of $19.8 million loss. And one thing to note, and when you're looking at the financials, is Last month was 28 days in February, and of course, 31 in March. So that does a variance with revenue, so that's yet 3 extra days in March. So one thing I like to do is go to the chart. This is a new chart that I added last month, and it shows you the breakdown of expenses by category. And you'll notice this month's salaries were a bigger percentage, but that's because the other costs were lower. So it just made those a bigger percentage. So any question about expenses before I go to the balance sheet and cash flow?
I don't know if this is the right time to bring it up, but do we have a plan for the cath lab?
Yes. Dr. Bullock and I both have been in touch with the cardiology department at Vanderbilt. We now have 2 cardiologists on board here, neither interventional. We have a third coming in July, also not interventional. So I think we're going to have the consultation clinic call coverage in-house, but the Vanderbilt seems amenable to covering interventional procedures. I toured the cath lab we've been hearing about for so long. I wanted to see it. It's state of the art. And I did learn that we, in the past, have done both diagnostic cath interventions, even in treating acute infarctions, and we have the equipment, we have the staff that can handle this. We just need the interventionalists themselves. And Dr. Bullock, do you have anything else to say about next steps there? Or okay, but it's being pursued.
I had one other question. Do we have capacity in our specialty clinics for more patients? We do.
We do have capacity, yes, sir.
Okay. All right. I'll talk to you about it.
All right, any other questions? We're going to head on to the exciting stuff now. So we're going down to the, we'll skip the balance sheet and go to the cash flow statement, because that's where the money is. So one thing we will be doing is changing the format of the cash flow to match what the external auditors do for us. So it will be a lot more detailed than what you're looking at. This is kind of a summary version of the cash flow statement. And what it shows that the cash from operations for the month was we had a cash loss of $1.2 million off operations. And then for the year, $17 million off operations. Now, down at the bottom, you'll see the change in cash, and we had a positive cash flow for the month of $2.2 million compared to a year-to-date of $7.8 million. So overall, that left us with $5.6 million in cash for the month, which means for the year too. So some changes, not changes, but where cash came from, deferred subsidy from the city that we get every month. We requested more than we normally do to keep us in positive cash flow. We also got money from our capital funds from Metro that helped us out, and patient AR also decreased by $2.5 million. So any questions about this report or anything else?
Thank you, Mr. Moran, for your report.
And we're going to continue to close on time. This month we closed by the 10th of the month.
Congratulations. Thank you.
So we've come a long way.
This brings us to our contracts, and they have been thoroughly reviewed in the Finance Committee. So I've asked Dr. Hudson just to summarize for us, and I'm glad to chip in as needed, and Mark is present for any questions. He presented most of the contracts.
Thank you, Chair. Happy to do so. So we were presented with 5 contracts on today. 4 essentially are renewals. And so the first 3, I asked that if there are any questions that we wait to the end, and then we can identify the individual that was responsible for presenting them for clarity if necessary. So the first one was presented by Dr. Mark Brown, which was InterSource Mid-South Satellite. The initial contract has already been approved, so this was essentially a security piece that was protective of the hospital's cable signal from being pirated. And so we actually have a cost savings with this particular contract from previous year, and that cost savings was a little shy of $900. So we were excited about that. The start date will be adjusted to reflect today based on our recommendation for approval. So that was the first one. The second one was also presented by Dr. Mark Brown, and it was from Health Catalyst, and you may, I'm sorry.
Let's go ahead and
ask questions.
And see if there's any questions. We'll approve them one at a time if we can.
Okay.
Do you hear a motion for approval?
So moved.
Any discussion? All in favor?
Aye.
All opposed? That passes. Thank you.
All right, this next one, Health Catalyst, you may recall Dr. Brown presenting it last month. The issue with that one was that Dr. Webb had signed it, and so we needed to adjust the signature if I'm remembering correctly. And so as a refresher, this is a contract that provides cancer data abstraction and reporting. And so it is something that is necessary for accreditation requirement and compliance, just state compliance that we need to be mindful of. So the committee did approve it after much discussion.
Do you hear a motion?
Motion.
So moved.
Second? Any discussion? All in favor? Aye.
Aye.
All opposed? Motion passes.
All right, the next one is from Registry Partners, also one of Dr. Brown's. This again was a renewal. And I had the question, how does this differ from the registry? So this one also deals with our cancer registry and reporting. And so the previous one that we just approved is more about accumulating the data and sorting, et cetera. And this Registry Partners is more about how we present that information. So this, again, was a renewal, and the the committee approved it, moved for approval. So I seek approval here as well today.
Any questions? Okay. Hear a second? Any discussion? All in favor? Aye. All opposed? Motion passes.
All right, this one was a little bit exciting. This is KPMG, which is, this one is Accounting and Financial Reporting Assistance and Operational Efficiency Improvement Assistance. Essentially, this is an advisory services type of contract, and we'll be in collaboration, or this contract is in collaboration with the mayor's office and at the suggestion of. So a lot of work has been going on behind the scenes with this, and so this will help improve our finances and operation, and there will be a deliverable. So this contract is just shy of 3 months, and so this contract is from May 1st to July 31st. With some anticipation that we'll have some deliverables in August. The question was presented if there will be some type of action plan based on that deliverable that can be shared with the board, and was provided a lot of confidence. And Dr. Blackledge talked about already building in opportunities for those advisors to come and to present to us at least twice, I think, twice throughout the process. So as we have questions, so we can understand what's going on, et cetera. So the cost of this is $910,000. And there were a total of 3 bids, and we've discussed that, and this was this worked best for us. Dr. Blackledge also was transparent in saying that that she was had the opportunity to work with each of these, so she does have some knowledge of working with each of these people that were up for, companies that were up for bid, providing proposal, and this is the one we went with, and some really thoughtful negotiation also took place. So after that lengthy discussion, we decided to move for approval, and we hope that you do as well. Open for questions.
It's my understanding that the $10 million subsidy that the mayor and the council kindly provided for us, this was an integral part of this, and so that's how this is being funded. Any questions, Mr. Lesser?
Just out of curiosity, the other two, was their cost similar?
Yes, so we talked about that. That was my question, and she did want to provide some level of privacy because this is an open meeting, but we were able to discuss that kind of offline, and I was able to see what those quotes were, and I too am pleased with the services that we will receive and the investment that we're providing in this. So I'm sure she's happy to do the same for you, but I think we're in a good position.
Yes, Derek.
You may recall an opinion was issued about a year ago about when you consider contracts for professional services. Yes, you evaluate the cost to some extent, but they're really awarded based on their known for their professionalism and also their ethics. That's the criteria used when evaluating the proposals for professional services. So just, but as they stated, pricing was considered to some extent, but it's being awarded, as I understand it, on the qualifications.
Thank you. Any other questions for Dr. Hudson or Dr. Blackledge? If not, may I get a motion?
So moved.
Second.
Second.
Any further discussion? If not, all in favor? Aye.
Aye.
All opposed? Thank you.
Lastly, we have Gallagher Insurance Broker that was presented by Ms. Lewis, and this is a renewal. Insurance for directors and officers, cyber insurance, as well as umbrella coverage and crime insurance expires in a quick minute. So this will be effective May 1st. So time was of the essence of this. So this one had some additional costs because we have a $1 million umbrella limit right now, and the recommendation far exceeds what the suggestion is. So they're suggesting $5 million, but it's still not quite on par, honestly, with some of our peer institutions based on size and services rendered. And so, but it helps. It's better than what we have is what my takeaway was. I feel free to clarify if I'm misspeaking. So last year's cost for insurance was $115,762, and what they are hopeful for and what the committee approved was $166,000. And that was to include the umbrella policy. That was the most significant change. There was a $5 million sub-limit option and these different things. But that is by far what the ask was. And so this is like a little bit of a difference, and they've worked with the finance department. They've helped identify where the offset will come from. And so that was a key point of discussion at our meeting is where do we get the funds to pay for the offset? And so those funds have been identified, and we feel like they can make it work. So again, time is of the essence. We felt like we are vulnerable from cyber risk and other risk, and so to have the additional coverage would be beneficial, but also that we were in a good position to allocate the funds somewhere else, or the funds will be allocated from somewhere else. For that point, or because of that, the Finance Committee moved for approval, and I am hopeful that you all will as well.
Move to approve.
Okay. Second? Anyone? Do I hear a second?
Second.
Okay, thank you. Thank you. Any discussion about these contracts? If not, all in favor? Aye.
Aye.
Please. All opposed? Motion passes. To the board chair's report. First of all, I'd just like to comment about my experience over the last month or so. I think it's become enjoyable to be on this board. I look around at the board members that are here. Each one of you is contributing very significantly in different ways. And I've also spent a bit of time in the hospital and some of the outposts, getting to know some of the managers and directors and staff. And, you know, people ask me how things are going at the hospital. I feel like the board, the hospital is sort of levitating a few inches higher maybe than it did in the past. I see a lot of optimism out there among the employees. I mean, there's some anxiety, you know, who are we going to get? What's it going to be like? But we got a lot of great people working here, and I sense encouragement among them. And, you know, I truly think we have an opportunity to continue to provide great care here in the hospital and to move us forward into a new era. So it's encouraging, and I appreciate the opportunity to be involved. I will remind you that in June we will have officer election again. So I would ask Dr. Miller to be scheduling the nomination committee to meet sometime in the next several weeks. I don't think we really need a report of recommendations until June, but it takes some time to get these things done. And Janet to, again, just circulate a questionnaire of who among the board members is willing to serve and what positions.
When does the term expire? In the May or in the June?
We have an election at the June board meeting.
Okay.
I have also had the opportunity to meet with some folks in the community and specifically with the organization NOAA, Nashville Organized for Action and Hope, who had expressed some concerns about the direction of the hospital. We Dr. Elders and I met with them, and we had a great discussion. They are an advocacy group, and you know, I asked what we could do for them and what they could do for us, and we talked about our budgetary needs, about capital allocations, and about the need for a study for what a great safety net hospital looks like in 2025, and they took all those requests to the mayor and met with the mayor this week, and I would encourage board members who have connections in the council and with the mayor to advocate for us for our budget. We have a capital list, and it's significant, but the things that we really need just to keep us afloat and get going amount to about $8.6 million. That's a little bit more than we've gotten in the past. 2 years ago, we got about that much. We need to sort out exactly what it is for this year. But you know, if nobody says anything, then decisions are made in one way. If we have advocates, then I think that is helpful. So I would encourage you to do that. And I will now turn it over to our newly appointed interim CEO.
Thank you, and thank you all for that. So some of the things, I provided a written kind of document in your packet for our Hospital Authority Board acting manager report at the time. I've already covered the employee spotlight. I did include a section on our executive leadership rounding. The ICU is recognized this time. I need to come closer to the mic. For the professional services agreement, we did already provide an update on that. And Dr. Blackledge did inform me prior to this that the PSA Finance Committee group did have a joint education session today that was very enlightening for both parties. I did meet with Dr. Hildreth on March 27th as well as this past Monday, April 21st, and received an invitation on yesterday to attend their board meeting in May as an introduction. The Metro Internal Audit Report details we've already gone over, as well as the Human Resource Department Audit Report. We do have some challenges. As you see, the census has declined over the last 2 months. We attribute that drop to the negative media coverage surrounding the hospital following Dr. Webb's departure and some possible, federal immigration changes, but we are working to increase that volume. As indicated in the finance report, salary expenses continue to be over budget, and a corrective action plan will be incorporated throughout May and June to align our costs with the census. One more challenge for us is the grant from the National Institute of Minority Health Disparities, which supports portions of several salaries in CHIN. That grant ends, and there was a typo, it's April. I thought June, but it's April 30th, and we are working on provisions for that moving forward. You do have a calendar of events listed in your report, as well as an operation snapshot that gives you our last 3 months volumes for ambulatory ED admissions, deliveries, and things of that nature. Do you have any questions for me?
I have a question about what we expect to be the benefits and actionable items from the KPMG consulting contract that we approved. As I understand it, is sort of two-pronged. The first being a lot of blocking and tackling for accounting and finances.
Yes, sir.
And the second big category is strategic planning and operations. They're going to sort of talk to executive leadership. What do we, at the end of this process, when we get their findings or conclusions or recommendations, what are we most excited about learning from their work?
Dr. Blake, we both can tag to. I'll say for me, I believe I'm excited that we'll have a financial infrastructure that will be a little more transparent, a little more accurate. There are just some, disparities in information, and that we'll have confidence of Metro Finance moving forward after we finish this consulting adventure. Also, they'll be looking at our operational efficiencies, and I'll just be transparent. And I'll say this: I've been transparent with every single department in this building and all executives. When you look at our salary expenses, we're at like 876 employees, and we have 117 leaders. And so we want to make sure we're following industry standards, and that will be a piece of that proposal as well. Dr. Blackledge does have additional information about the financial piece. She's the subject matter expert there.
Yeah, so when we thank you for the question, and thank you, Dr. Elders, too, on that piece. So when we think about this, we have gaps in our business practices today. We've spoken about that openly in some of our board meetings. And so we're tasked with ensuring that we keep our commitment, which was economics, accountability, and culture. And so when we talk about the deliverables, it won't be like at the end. So at the end, at a conclusion, it will be it's a working process to input those tools that we need. I think I heard the word confidence used. That's one, but input those tools for what we call our standard operating pieces. So our procedures, updating those to today's environment, to the actual work that is occurring today. when we think about month-end close, when we think about year-end close, when we think about our audits, all those actionable items that we need to take as an organization. So that would be what I call Part A, and that Part A has a lot to do, when we think about the outcomes, is speed, is execution, and is taking the action, right? So we don't want to spend 3 years or 4 years working on it piece by piece. Let's take the time, hit the reset, ensure that we have the right infrastructure. The other component to that accounting infrastructure is, as we decide collectively what our next steps look like, part of that decision-making has a lot to do with our finance piece, the reporting of it, making sure that our department leaders are receiving information timely. Those are some of those items that deal with Part 1. The second part of it, Dr. Elders spoke to it, is what do we look like from an operational efficiency piece? When we think about these things, because we're here every day, we don't get a chance to go into other safety net hospitals and talk about how they operate and what their model looks like. So what should our business model look like? How are we going to operate? And so it gives us the tools that we need and prepares us to even have the conversation with you, our board. So when we think about those things, it kind of comes all together. I can refer to it. I heard Dr. Martin use the word augment earlier, an augmentation. So it's an augmentation, it's an uplift, but it's what's needed for the organization, given our current situation and where we are today. Keith spoke to some of the cost reduction strategies, and I've spoken all along over the last 3 months, and I did a little bit in finance committee about it. So we're doing that work, but there is other work to assist us in what we would call stabilization and kind of how we move forward. So does that help?
Yeah, very much. Thank you. Because I mean, it's a significant investment. I know that this is important to Metro Finance and the city leaders for us to do this, and that has its own value, but it seems like we are making a significant investment in these advisory and consulting services. So I'll be eager to see how that goes and what we can learn from it.
Well, thank you, everybody, for being here and for your contribution. Any other comments or?
Well, I'd like to.
Dr. Nettles.
I'd like to make a comment. Since we are in a situation in a very exciting time for a change, and if it would be at all helpful, I would certainly, on my own dime, on my own time, be willing to visit other hospitals and do some of this interview or reconnaissance. You all give me some questions or whatever, and I don't mind doing the sleuthing. But if that would be helpful, I certainly would love to be a part of that. To have just see, since you can't get out and see, the things that I would love to do that.
Thank you. And we, Dr. Eldridge and I have discussed that, and I think we'll make that happen. Thank you and we'll include you. Thank you.
Mr. Chairman, and Dr. Nettles, a new role for you as a sleuth. That's great. As the board's representation on the foundation board, I just wanted to give you a quick update that some new folks have been added, as well as myself, to the foundation. And unlike this board, that board can actually meet outside of board meetings and discuss things with each other, which is going to be rather interesting and I think rather productive. But I think the important thing here in this transition we're going through is that there is this wonderful opportunity for alignment with the hospital itself, the needs of the hospital, and the foundation in a way that maybe hasn't been quite in sync of recent years. And so there's an eagerness on the part of the foundation members to be part of that and to support. It is my opinion as a board member here that the foundation supports this hospital and should not be on its own determining what the fundraising activities should lead to. I think there's a responsiveness to that because there is now an opportunity to guide that foundation in a way that maybe was a little bit less so in recent years. So there's, as you mentioned, Mr. Chairman, a great deal of enthusiasm here at the hospital. There is also a great deal of enthusiasm to align these two organizations in a way that's productive. Thank you.
Thank you. Any further comments or business?
I just wanted to thank you, Mr. Chairman, commend the leadership of the hospital. A transition is a very challenging time, but as someone who practices in the hospital, at every level, the leadership of the hospital has really risen to the occasion, not just from continuing to do the best for the hospital, but also continuing to reach out. Just two good examples of that. So we had the transition with the vascular surgery situation, and I'd like to thank you, Dr. Martin, Dr. Elders, and the CMO. Everybody rose to the challenge, and within a couple of days, we were able to get Dr. Fisher to step in. I'm a nephrologist, so our patients have a lot of vascular stuff. So being able to manage that change without breaking a stride, that was beautiful to see. And then for so long, we have struggled with making sure that medical students get access to Cerner. And the IT team really rose to the occasion, and they were able to pull off in the past 2 weeks what we couldn't do in the past 6 months, which is getting medical students to have access. And that's the workforce for the future, for the state, for Davidson County. So it's really been beautiful to see. So I just want to commend the leadership and let you know some of us, the providers, are very excited about where we are. Thank you.
Thank you, sir. We appreciate that. And with that, we will adjourn and reconvene on May 29. We will discuss in the search committee meeting whether if we choose a search firm and we can negotiate with them, and there's still, a couple of weeks before the next meeting, whether we might consider a called meeting to expedite things. Thank you and good night.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.